Welcome, everybody, to our short course introduction to decision analytic modeling or to decision analysis here at the 41st annual meeting of the Society for Medical Decision Making in Portland. We're welcoming you very much, and we, that means Assistant Professor Viata Yan from UMIT and myself, Uwe Siebert from UMIT. We will introduce ourselves briefly and then start with a round through the audience so that you all can introduce yourself quickly as well before we then go into the matter of the course. This is where we come from, the wonderful mountains of Tyrol, UMIT, the University for Health Sciences, Medical Informatics and Technology in Hall in Tyrol in Austria. I start with myself. I'm Uwe Siebert. I'm a physician by training, and I'm currently the chair of the Department of Public Health, Health Services Research and Health Technology Assessment at UMIT. I'm a professor of public health and medical decision making at UMIT, and I'm an adjunct professor for health policy and management at the Harvard Chan School of Public Health. I'm also working in OncoTyrol, a Center for Personalized Cancer Medicine, where we do applied research in personalized medicine, and I'm also affiliated with the Institute for Technology Assessment at the Department of Radiology at MGH in the Harvard Medical School in Boston. I'm with the SMDM for a long time already, so this is more like my family than my job. And I was also the past president of the society, and we're giving these courses over a long time. And one of the favorite ones is this is one of the core courses in medical decision analysis. My research interests are in health decision sciences in general. And also, I have a particular hobby, let me say, or focus on causal inference, so taking causal parameters, putting those into decision models. Because of the job leading a Department of Public Health, the focus is very often on preventive strategies, benefit-harm, cost-effectiveness, and but also screening, and we do basically all kinds of diseases. Cancer, cardiac disease, infectious disease, but also treatment and personalized medicine. In teaching, I teach decision analysis here and at several other universities at UMIT, also in the summer course of the Harvard School of Public Health. I'm also teaching health technology assessment, and I just came out of a course of SMDM, causal inference and big data analysis. I hand now over to Beate.
Thank you. Yeah, I'm Viata Yan. I'm an assistant professor at UMIT, University for Health Science, and also I'm a lecturer at Harvard Chan School of Public Health in Boston, and I'm a senior scientist at the division for HTA at OncoTyrol, the Center of Personalized Cancer Medicine in Austria, and I'm currently vice president-elect here at SMDM and our society. And I'm the president of the ESPOR Austrian chapter. How about my research interests? Well, my main focus is on health decision science, economic evaluations, and the field where I've applied it in the recent years was mainly in cancer screening and treatment, but also I do some work in quality of life and patient-oriented outcomes research. I teach decision analysis at UMIT, at the University in Munich in Germany, and also at Harvard. And we teach short courses, as Uwe said, here at SMDM in North America, but also in Europe and Asia.
Thank you very much. So I go on with some acknowledgements. So this course had been supported by other people, Nikolai Mühlberger, Ursula Rocha, Martina Kloib-Schädel, and Viol Zakharimi. And it was also supported by the OncoTyrol Center. They funded part of the time we had for developing this course. So before I go into this course particularly, I would like to ask a few questions around, and then maybe each of you can quickly say your name and from which field or university to come from. So just very briefly that we know who is in the room. But let me ask one question in general. Who comes from Europe? Who comes from, one person from Europe? Who comes from Africa, Asia, Who comes from one of the Americas? The rest. Comes somebody from South America? Okay, so main people coming from the US. That was easier for you to get here, so I had a 23-hour travel time. And I'm quite jet-lagged, but very excited now to teach this course. Who comes from the field of medicine or nursing or some therapy that you work with patients? That's very nice, because that is important in this course. Who comes from mainly from research? Can do both. And who comes from an authority, maybe a health technology assessment agency, a payer, a sickness fund, or something like that, healthcare plan. Who comes from an area I haven't mentioned, patient organization, something else that I haven't mentioned? Pharmaceutical, so company, okay. Any other manufacturers, okay. Good, so that's a nice mix, so you can basically learn from your different questions, probably as much as from us. Let's do a quick introduction round, starting here and then going back and back here. And just quickly say, I would ask you to say your name and where you come from, your institution, and the field, whether that is whatever, psychology or medicine or public health. You want to start?
My name's Heather. I'm from Salt Lake City University, Utah, focusing on health services, research, and rehabilitation.
Thank you.
Larissa, I'm from Oregon Southern Science University. I'm local to my field mission, just before then here. I am with the Department of Public Health and Cardiology, epidemiology,
Thank you. Okay, thank you. Welcome to SMTM. Okay, nice to have more Tyroleans here. Thank you. Thank you. Thanks. So we do have somebody from an authority. Thank you very much. I already figured out that when I listen to the last row, it's harder for me to hear you. So please, if you have questions, try to speak up, and there is some air condition going on here. So I will repeat questions if people ask something, and also repeat some of the answers if I have questions, so that everybody is with us, and that helps also with the recording. As mentioned, this course is recorded. You will not be recorded, but just the speakers and the slides, and a combination of the two will afterwards be available. And we adapted our teaching style a little bit to that format, so we won't walk around a lot between the chairs, and so that we escape the camera. And another thing I wanted to ask you, please interrupt us when you have direct, immediate questions, and otherwise we will have little breaks when we ask whether there are questions at each part of a little session. So this course is part of the core course program, which the educational committee, together with other short course committee and other committees, has established a long time ago. The core course curriculum of SNDM includes 4 courses, which are listed here. Introduction to Medical Decision Analysis is this course. Introduction to Psychology of Medical Decision Making, Introduction to Cost Effectiveness Analysis, and Introduction to Shared Decision Making and Patient Decision Aids. If you get these 4 courses together, you will receive a certificate of completion of this program. Additional courses will be added. Let me just quickly ask, anyone has already participated in any of the other courses? Okay, many, that's nice. For whom this is the first course of that curriculum? Okay, so that's a nice mixture. Thank you. So I encourage to continue with this, because it's really a joint picture of these 4 different views that we do. The objectives of this course are the basic understandings of the goals of decision analysis, the concepts, the methods that we apply. Then secondly, the basic methods, including decision tree and Markov modeling as model types. And you should also be able, after this course, to know when to use which of the 2. Also, we will present further modeling types, not deep, but at least that you know what's the difference and when you should go to which modeling, and then probably a different course to go deeper. Also, the question should be answered after this course when you do need decision analytic modeling and when you don't. And we will then, after the course, also ask you, what do you see as strengths and limitations of this approach? And we may add to this. This is the overview on this course. So starting with this a very short session on the decisions and trade-offs. So what is that about, decision analysis? And then I mainly spent the time before the break on a case example, diabetic foot ulcer. So we will immediately jump into a case, and then some of the theory comes afterwards. After the break, then Beate will continue with the concepts of decision analysis and going through the rest of the agenda, and also talk in the end about good practice for decision analytic modeling. And then we will jointly give an outlook and checking back with you what you think are the strengths and limitations. We have a half-day course. So what we did, because we have larger courses, we have left some of the slides of a larger course, and they are indicated with these start slides with this asterisk. So if you see an asterisk on the headline, that means I'm going to just skip this slide. We'll not talk about it, but you have it in your handout, and you can go on and read deep. And sometimes if there is a question, we use some of these start slides to go. There is also course literature, which we have assigned to this course. It's the big book about decision-making, health, and medicine by Miriam Huning, former president of SMDM, and she has also contributed through a lot of courses and teaching to this field. So that's a big book. You can't read that just in one chunk, but that's something for a longer time. Then I've also added one of the articles. I was asked some time ago, when should we use decision analytic modeling in economic evaluation of healthcare, but it's more general. So even when you do only benefit harm analysis, that is helpful. That is much shorter, and you can read that on a quick run. We have given you more course literature on this star slide. and that includes also all papers that have been developed through the ISPOR SMDM task force for modeling. So these are guidelines which are now also requested by the journals to be followed. So if you want yourself develop and publish a model or modeling results, it's good to know these papers and to follow that rules. That aids speed for publication definitely and saves you some review rounds. They cover different types of models and some general aspects. Decision-making in healthcare. What is it about decisions? Well, we have a lot of decisions to make in healthcare. That's an essential part. And that also includes also weighting and trade-offs between different goals we want to achieve. So we may have a drug that has increased benefits in terms of extending life expectancy, but there may be some risks of side effects, or there may be some chemotherapies that reduce quality of life while you get the treatment. So there are risks and harms associated. And then finally, you may have something that is better and has less side effects, but it's much more expensive. And then there is the trade-off: should we really use societal money and fund that treatment, or is there something better treatments, other things that we can do in healthcare or in our society? So these are trade-offs. And when we have trade-offs, the decision analysis comes in, and we need a formal way to weigh these trade-offs against each other. It is quite simple when we have something that saves lives and that kills lives, because then you can just subtract the mortality through an intervention by the gain in life saved or life expectancy increased. But sometimes the gains are in life expectancy and the harms are something else. They may just be pain or some other harmful effects that don't kill you. And then the question is, how much of my lifetime am I willing to give up to improve my quality of life, or vice versa? So these are trade-offs which we then try to formalize. When you don't have a trade-off, when you have a technique or a technology or a drug or a device, and that works better than the old one and has less side effects and is cheaper, then you don't need a decision analysis joining these things and weighing them against each other. The next aspect of decision analysis is it's made for situations of uncertainty, and uncertainty in different levels. So if we have a risk of side effect of 5%, that means some people may get the side effect, some others don't. So that's uncertainty on the individual level. Then we do studies, and we have confidence intervals and p-values, never perfect knowledge. So we have uncertainty on that second level about the effects themselves. And all that together basically is captured by the tools of decision analysis. So making decisions under uncertainty. What that means is we're not saying for you it would be better to do this because you certainly will survive and the surgery will work for you. It basically means that we increase the chances. It's like gambling. It's like betting on the best horse. And in this case, it means we would like to tell you that with this drug, you have a better expected value. With this screening, you have a higher risk of overdiagnosis. So that's what we produce. These are all expected values. And the expected utility and value theory is behind what we call decision analysis. So decision analysis as a definition is a systematic approach to decision making under uncertainty. It's quantitative, we calculate, and it's also very transparent and explicit. So it's widely used in decision making, in clinical decision making, in economic evaluation, health technology assessment for all kinds of technologies or procedures in health and medicine, preventive, diagnostic, therapeutic. And it involves combining evidence also from different sources. So some parameters may come from progression studies, some from mortality studies, some from quality of life studies, some from resource utilization studies, cost studies. And then we have to join them and make a joint picture of that. So it's a tool of evidence synthesis. The sources may be epidemiologics, that means observational studies, RCTs, or any other quality of life service, so different types of study coming together. So the difference between decision analysis and meta-analysis, which some of you may have used, is that it includes also different kind of studies, different parameters, but also different comparisons, not just one and the same thing again and again. So that makes it more comprehensive, but in the same way it makes it more vague, and we need more assumptions to join this evidence. So what are trade-offs in health decision science? We all want to get benefits from a new medical procedure, but we also know that often that comes only with additional harms. The more aggressive, the more toxic a therapy is, the more we can have that side effects. The next thing that comes, whether we like it or not, is uncertainty. So that's on the side of disadvantages here in gray on the slide. But that is not something that we only want to get rid of. It's something which we want to systematically and explicitly tackle and analyze. And that can actually help in some situations to define further research. And then definitely a disadvantage of some of the technology is the costs, but it's not actually the costs, it's the opportunities we lose if we invest money in something and we cannot do the other thing. So you can also see that in spending money for something that helps makes sort of taking money away from another vaccination or another purpose you can do. We call that opportunity cost. So you would have to subtract the lives you could have saved with the same resources. Some economists like to call that the economic side effects, because you lose other lives when you spend money and saving these lives. Very formal, the language of health economists. Now, with uncertainty, there is one thing. Uncertainty can actually become our friend for further research. If we use decision analytic models to systematically look which of the parameters is so uncertain that it really is influential for our result, and it could tip the result or the decision, to in favor or against the drug, or in favor of drug A versus drug B, then that means we need more information on that parameter. And often that is not the effectiveness or the efficacy of the drug itself. That could be, for example, in a screening, it could be the prevalence, or it could in a diagnostic test procedure followed by a treatment. That could be the sensitivity of the diagnostic test. So what decision analysis can help us find the parameters that are influential for making better, more certain decisions, and that means we should invest money in further studies, getting the prevalence or getting the sensitivity of that diagnostic test. Overall, we call that value of information analysis. That's a very high level, sophisticated level of decision analysis. There are sort of 3 levels, and that's level number 3. We're not going to talk about this any further in this course, but there are courses at SMDM who talk about value of information analysis. So what are the typical decisions and trade-offs we face in some of these areas? So you may know that diagnostic tests come with a threshold, an ROC curve, and you have to trade off sensitivity versus specificity. Who has worked in that area and has generated an ROC curve? So you have the question, should I lower the bar and then I detect more people? True positives, but also false positives, or should I not do that? So that's one trade-off. Decision analysis can systematically help to optimize and find the optimal trade-off, or the optimal cutoff of a diagnostic test. Then treatment, we have already mentioned, there is efficacy and side effects, and we have then examples where we do life expectancy, we gain life expectancy, but we lose quality of life, or we gain quality of life, but we have to sacrifice maybe some life years in order, on average in the population, to get there. Then costs versus health effect, we've talked about that. What's the society willing to pay for something and not using that money somewhere else, that resources? In the end, it's not about money, it's about the resources. It's the nurse that could do something else. It's the physician that could do something else. It's the hospital which stands on land, which we can use for something else, and so on. So that's what we call, in economic language, opportunity costs. Then there is something which we will not cover in this course, but it may also be very interesting in some psychological or patient-shared decision-making. It's risk preference, so people can be aware of the risk, and they say, well, I'm rather careful, so if you say there is a 5% chance, never leave this hospital again, so I rather stick with my disease and live my next 7 years of life expectancy, and I omit the chance of getting cured just to take what I have. And there are people who say, no, this is not the life I want to continue. So even if the chance is higher, I'm going to take the risk of this risky surgery, and I want to get rid of. You all see these, know that from your life, or if you're not in providing medicine, you look at Grey's Anatomy or other things, and you see how patients are different. And some people say, no, this is what I want to do, and this is what I don't want to do. Decision analysis can actually also help with that, because that risk averseness and risk seekingness, we call that risk posture, is also quantifiable, and there are methods to quantify that degree of risk averseness. Whether you want to do that or not is another thing. Whether you want to have somebody calculate for yourself. But for example, if you buy stocks, that's what's done there too. There are some risk mechanisms behind that, and people ask you whether you're a risky person or a risk-averse person. We cover with decision analysis interventions of all types. That could be prevention, in primary prevention. It could be secondary prevention like screening, early detection, diagnostic sequences of tests, combinations of tests, which are followed then by a treatment, therapeutic strategies or combinations of different things, and any other either even management procedures. How should we set up the hospital? How many beds should we have in order to optimize the use of that resources? So the next slides, I don't go through them, but they give you a little collection of how decision analysis is used in that different pockets here. And they give you some topics. And then I have on start slide, I have the abstract. So if you want to read them in your own time, you can see what these people did. Some of them are actually from the society here. So this is from Murray Cron and his co-authors, former president of SMDM. He was looking in the current and projected annual direct costs of screening for prostate cancer using the PSA test, prostate-specific antigen test. And the trade-off here was you may detect something and cure that patient and save lives, but you may also destroy a lot of quality of life because the side effects can be very severe. They are usually not deadly. Some of them could be. Infection after a biopsy could lead to death in very, very rare cases. But you could hit some nerves in the surgery, and that could lead to severe side effects and a reduced quality of life, incontinency, or sexual dysfunction, or other things. So that's a big trade-off. So you have to make a decision whether you want to undergo that screening. We're talking about healthy people, not sick people. So that's prevention or screening, secondary prevention. Then another example is, at least the women among you know that there are different options how we can do screening for cervical cancer. And the question is not just should we be screened or not, that may be the question for prostate cancer screening, but what's the interval? And how often should we do, and which tests should we combine, and what should be the rules then for that? And that's an example where we didn't even look at costs. That was just a benefit-harm analysis to guide physicians and guidelines and patients and women to make their decision regarding how often should I undergo screening. If you go more often, there is a higher chance of getting a colposcopy, for example, and some interventions, which itself has complications. But then, of course, the risk is lower to overlook cervical cancer. So there are always these trade-offs. You can overdo medicine, and you can underdo medicine. It's like dosing. You can do something very intense, very often, very frequent, or be a little bit more conservative. That's an example, Miriam Huning, also the author of this book, who looked with her team into different diagnostic methods, non-invasive imaging methods, and compared them to find out what's the best among these and what's the best sequence. You may take one first and the other second, or vice versa. So diagnosis is one of the cradles of decision analysis because you have to include information and then make another decision on treatment. We call that linked evidence. So the sensitivity and specificity of a test must be linked to the treatment effectiveness, and both together can help you to make the decision in a formal way. This is an example of myself and my group. We have spent a lot of time looking at antiviral treatments. We had different regimens over time, and they were usually increasingly effective, and also costs increased. So what's the cost effectiveness of that? Other examples include sequential treatments. You all know that sometimes we have first, second, third line treatment. What's the optimal sequence? There are no trials that do AAA, ABA, ABC, CBA, and all that. So you have to join that current evidence under some assumptions to help find out what could be potentially 2 or 3 ideal sequences. And then you can take them after you've done a decision analysis and test them in a randomized clinical trial, but you cannot test 10 or 20. Then in management, breast cancer management, also personalized medicine. This is an example of Viata with her group, where she was looking at the cost effectiveness of personalized treatment after the application of Oncotype DX and adjuvant online to guide the chemotherapy in Austria. So these were just a quick round through examples that you know decision analysis is really about all these areas. Did you miss anything? I mean, I could extend this list with many, many examples, but it's important to see it starts from primary, secondary prevention, it goes until treatment and personalized medicine. So it's for public health, it's for individual medicine, it's for guidelines. Questions at this point? Okay. So now I'm going to start with my case example of diabetic foot ulcer. Who had patients with diabetic foot ulcer? Okay. So I'm going to ask you afterwards to help me teaching this course, or at least when we have questions, to take the help of our professionals here. Who does not know what diabetic foot ulcer is? Has not even met that in the research on medicine. So I'm going to give a very, very brief introduction for those who have been are less familiar with this disease and symptom. So we take this example in this course because it's quite simple, but it has already the ingredients of trade-offs and decision analysis. How I presented the example comes from Milton Weinstein's book, one of the founding fathers of decision analysis and cost effectiveness. He was my thesis mentor decades ago. And in this book, he basically used that example and calculated at that time, still with a pocket calculator and by hand, in a book chapter about clinical decision analysis, what would be the preferred strategy. It's a simplified, I present it as a simplified example, so don't take that as a clinical advice and go to your patients, oh, I've seen this is the best for you. So this is really a sort of a toy example as a disclaimer, but it includes the ingredients, and meanwhile there are more of these publications and more sophisticated models, but in the end they more or less do the same thing. So the case example is a 60-year-old patient who suffered from peripheral vascular disease and now had a foot injury and an infection. So the infection already developed with a possible gangrene in the left foot, and one response now would be prompt amputation. Amputation in an early stage, so this could be below the knee, and then you could use prosthesis, and there is sort of limited harm, but it's, of course, a big thing, have an amputation. So people are afraid of that, and we would like to avoid it. And there is also a chance that with conservative, good medical care, that foot can be saved, and the patient can continue with the foot. So it's a huge decision. But if this surgery is delayed, the problem can get bigger, and the gangrene could spread, and then the patient would need a bigger amputation above the knee, which is then more complicated to be able to walk afterwards. And also the risk of that amputation is a bigger one because it may have to be done not as an elective, but as a sort of an emergency surgery. Now, limb amputation in general is relatively safe, but relatively is relatively. There are mortalities behind that. People can die from both, from the smaller, below the knee, and the bigger amputation above the knee. And of course, the mortality is higher the bigger the surgery is, so it's higher for the above the knee. So that's a factor speaking against waiting. The factor in favor of waiting is, hopefully I can save my foot. That's a classical trade-off. So you go into a world which there is a better outcome and a worse outcome, and you want to decide whether you want to play that gamble. I haven't mentioned everything which you could consider, and there are a lot of additional factors, so let's keep it simple. Also, the numbers that I show you will be rounded numbers, so we can do the calculations without even a pocket calculator, or prepare your iPhone and your pocket calculator, because there will be some calculations to be done which you may need the pocket calculator. Comes up in the next slides. So when I ask you at that time now, who would think that we should do the surgery below the knee, or who would be in favor of wait and see? And let's assume you're the patient and you have to make the decision for yourself. And if you see your neighbor getting pale and falling off the chair, let me know, then we don't want to threaten you. But make it a realistic mind experiment, because things are easy to say on a course, on a piece of paper. But when you have to make the decision yourself, that's a tough one. And you definitely will not make that in the 1 minute I give you. So you will go home and talk with other people and make that decision. So that's part of what we do, the communication and so on. So who in the room would say, I would go for the amputation below the knee immediately, and I don't wait for the cure? Who would go there? One person? Who would hope and wait and see? Most of it. So what did you drive to say now? Now's the time.
I think the above the knee, well, I guess just my own experience.
Okay.
Setting, anyway.
Yeah. So the experience says there will be a progression anyway. That's just too much optimism to wait. Yeah, you need more information. Okay, I like both answers. That's his experience. So he may work in an environment where this happens. You may not be in the environment, or you may have been in a different environment, maybe with milder patients. And the other thing is more information. So we will come to that. That triggers my next question. So, but let me ask somebody who said, I'm going to hope and wait and see. Who wants to give me an answer? Why did you not go for immediate amputation? So you want to wait and get the chance. So she said there's a good chance that I can get the cure, and I want to try that before I go to amputation. But I'm telling you that that is at a cost, that at the cost of having a bigger amputation, and which has more mortality. So this is the point I want to make. Because if we can try and do something and have then a second chance to do the same as before, we always would try to hope and wait. The point is, do we have a trade-off? So in the decision problem you will tackle, next week in your work, you would have to see whether the additional waiting has a loss associated with it. If yes, then you have a trade-off. If no, it's a trivial question. Of course, we wait and check first. Yeah. Any other person? Why did you want to? So you would still have the optimism and hope, and not trying to do something too early, not intervene too early, which is sometimes a good advice. The question is how long to wait. So there is no answer, of course, to this, and I think the point is further information. So on what would you like to have information? So you're already throwing in what could be done to avoid this trade-off problem. But let's say there is nothing else to do. Let's simplify. So these are the other. But to make your decision, what is the information you would ask for? Probability of cure. Okay, that's one. Okay, so there may be factors that change the cure rate, right? What's the time window? How long can I wait? Lifestyle options? Okay. I'm missing one important piece. And before going on, let me do something. If you could ask me numbers that I give you, and not like, platelet counts or something, but connect it to a number. What's the risk in the next year? Something. If I could give you numbers for your patient, let's assume you have one patient, and for that patient, you would ask me the numbers, and I give you the numbers. How many numbers would you ask for? Let's take a minute to think that through, everybody for him or herself. How many numbers would be the minimum you would like to know that you can make that decision? And don't think too complicated. Keep the problem very simple. Right? We can have a cure or not, and then the amputation, you may survive or die, and so on. So keep it simple. So who has a number? No, don't tell me the number, but I'm just waiting until everybody has a number. And it doesn't have to be perfect, but it may be that I ask you which numbers did you choose. So don't just come up with a number of. Okay, so somebody wants to tell me the number? I saw your fingers. Okay, so 3 numbers. Who has more than 3 numbers? Who has also 3? Who has less than 3? Some people are missing here. So you have to make a decision. Now, the decision must be made. Okay, so what's the next thing once I'm through this? Is there a next one? Okay. Quality of life scores and priority of patients. It's not only about life years, right? So how bad is, how much more does an amputation above the knee give me disability compared to the amputation below the knee? That could be a number, like it's 3 times worse, or it's 5 times worse, and that may depend on the patient. You may ask the patient, that depends whether that's the job of the patient, whether the patient must walk or not, and so on. So that's an important factor, the quality of lives after the outcomes. We have a quality of life after cure. We have a quality of life after below the knee and above the knee amputation. We have a quality of life for being dead. Probably that's irrelevant. And then, what else did you find in your numbers? Well, you have one patient. You know the age. So you would like to ask what for that patient? What number for that patient? So this is how we are training sort of medical decision-making people. Try to say, this is the information I would need if I could get it. Even if you know I can't give it to you, but that's the first ingredient in the decision analytic problem. Hypothetically, if I knew the number, what was it? That helps you shaping the structural sort of decision tree or whatever we develop. There's one number I haven't heard yet, or maybe it was among 1 or 2 answers. So life expectancy, the mortality from the 2 different, right? I said it's bigger with above the knee amputation than below, but is it like, 1 out of 1 million and 1.1 out of 1 million, or is it 10% and 20 or 50%, right? So these are important numbers, the number of cure. So I give you some of these numbers, piece by piece. I'm ignoring for a moment quality of life. So we try to maximize survival. And the immediate amputation below the knee gives you a perioperative mortality of 1%, and the wait and see gives you a chance of cure of 70%, which is 0 when you have the, I mean, you're cured here from that foot, but you lost your foot. But that cure to going, back to normal, that would be 70%, and in case of progression, the amputation above the knee would be necessary, and that has a 10% mortality. So there is a huge trade-off going from this to taking a risk of taking that. So we're going to structure now that very simple problem. That's a problem some of you may actually have solved that with some probability multiplications, but we're going to show you how to do that structurally if you have more than just 2 or 3 numbers. So the premise in decision analysis remains. That's a difficult. Some people said, oh, that's difficult. I can't give you that answer, because how can you compare life expectancy with quality of life? You cannot compare food with long life. Well, the decision must be made. That's one of the premises of decision analysis. We're not trying to look for the truth. We're trying to do the best bet, get the best chances. Afterwards, we may say, well, in this case, it was wrong, but it wasn't the wrong decision. It was just having no luck. So what would it take to construct what we call a decision model or a decision analytic model? A model is a simplification of the real world. So what we do is we have 6 steps, which we now will do together with the foot amputation example. We first will define and rank health states. So what are the differences that you can have? Amputation above the knee, below the knee. What are the potential outcoming states of this? The end of the stories. Then create a decision tree, which is one of the modeling types, is a decision tree model. That gives us the structure of everything that can happen. And then we define outcomes, for example, life expectancy or quality of life or something else. And then we define the model parameters, all that numbers that we must plug into this structural decision tree to make it a machine that we can use, a tool that we can use to calculate something. And then we perform the analysis. It's only when we have the model with the parameters that we say we run the model, we run the analysis. And we do that in the decision tree model by averaging out and folding back, and you will understand what that means, averaging out and folding back. That's the technique, the analytic strategy to solve the decision problem. And then once we've done that, the result will tell us what's the expected outcome in each of our alternative actions, like amputation above, wait and see, or immediate amputation below the knee. We have 2 strategies that we compare in some examples. In some cases, you may have many that you compare, and then you want to pick the one with the optimum. And we will see that that's not trivial. And it depends a lot on the outcome, how you define number 3, the outcome. So let's start with step 1, define and rank the health states. So in our problem, what could in the end come out? We're not so much interested in the intermediate step, but what could happen in the end? How many outcome states do we have? Results. So we have cure. That's definitely the best, I guess. What's the worst? Death. For some people, maybe the amputation may be worse than death, but let's assume death is the worst. How much more do we have? Above and below the knee, so 2 amputations, that makes it 4 states. Anything else? Okay, let's take these 4, and that's how we would rank them, right? Well is the best, amputation below the knee is the small amputation, then the large amputation, and then death. So that's how you start. You don't weight them yet. You don't give them a score between whatever, 0 and 100 or so, but you have a rank. Then the next step is you create your decision tree, you create your model. If you work with other models in the future, like Markov models, discrete event simulation models, or dynamic transmission models for infections, then you take that model type, but you create it. You create the model. Yeah?
Why outcome essentially included in health state? Because that is outcome.
Yeah, that's one result that could happen. So even if you don't like to call this health outcome, but it's a state that could happen, and it's very important to capture that in the model. Pardon?
Is it the same outcome? I'm just confused.
Yeah.
Outcome.
So the question is outcome. The word outcome may be confusing, and I completely agree because we use outcome for so many things, for result, for endpoint, for state, what can happen. So this is why the better language is what I've shown here in the beginning, define and rank health states. And if you say, well, death is not very healthy, that's not a health state, but then it's a state. It's basically the state of, zero health or being dead. So you will see in a minute why we need to include that in our model, because we want to, some people would say that's the only thing I'm interested in, mortality, the risk of being dead. Then you turn it around. You can also say I'm interested in survival, so it's the chance of not being dead, surviving. So it must go in there. But it's important that we have more than well and death only, because in the end, you said it makes a difference whether you have the amputation below or above the knee. So we have to capture that dimensions of quality of life as well, and they may have different costs or whatever we do with this tree. So now we create, step number 2 is we create the decision tree. And a decision tree always starts with a so-called decision node. So you write the population of your interest. That can be one patient or the group of patients, the subgroup you're interested in. So that would be the patient with diabetic foot ulcer. And then you put there a decision node. So have people worked with PICO? You heard about PICO? What does that mean? PICO stands for population, intervention, comparator, and outcome. So that is a recipe how you frame a research question. In this case, it would be in patients with diabetic foot ulcer, what's the mortality, that's my outcome, of immediate amputation below the knee, that's my intervention, compared to wait and see. So with PICO, you can formulate very precisely a research question. And that helps us to do this. So the P stands at the beginning. These are the people. Now we show the comparators. The decision node, this blue square here, denotes that we can have different decisions. We could either, what is it? The alternatives we have, you tell me. Immediate amputation below the knee, and the second option was wait and see. So that's what we have. And you draw those. And the wait and see is a little bit more complicated because there is an if-then rule behind. You just don't wait, but you say wait and see, and if there is progression, then amputation above the knee. So complete your rule. We call that a strategy. Strategies are algorithms, if-then rules. And you can write them down as an intervention. Interventions can be rules like, we treat the pain until the pain score is lower than 4 points, or we start treatment of HIV if the CD4 count drops below a threshold, or we use statins if the coronary heart risk index is higher than 5%. So these are rules with if, and we call them basically treatments or strategies. So with one drug or one treatment, you can have multiple strategies. So what's the next thing that can happen? So this is a decision we can take. But now the decision is made, and the rest basically depends on chance or nature or fate. So what can happen? What can happen with the immediate amputation below the knee? You can die or survive. So that's the next piece in my decision tree. I have the green circle, which is a chance node. Nobody can decide on that. I mean, nature may make that decision, but not us and not the physician. So that's some fate or randomness in there. So some people die and some survive. And then we have the red triangle, which would be end of the story. So at that red triangle, we call that the end node or the terminal node. That tells us we have to put some outcome there. A number or a label, and in this case, after death, it would be, death or zero health, and after life, we would put something different. There was a question. So the question was, how do I know, or when do I know when that comes in? It's infection or not. So that always comes in when there's something that happens which has a mortality. It can be a small number. Often it is, luckily, fortunately, very small. But you have to make sure that you do not go to the right side without having checked, well, when do people die? Is there a difference in mortality? So you could say, I do the 2 amputations, and my outcome is amputation below the knee, but you still have to say, well, and then? And the next thing is, okay, after the amputation, I may be alive or dead. So think through the consequences. And usually in a good decision analysis, you think through the entire life. Studies go 5 years, 10 years, 20 years, but we want to have a decision analysis to inform the patient. And usually, colorectal cancer screening, you don't want to know what happens in the next 5 years. You want to know, or HPV vaccination, human papilloma virus vaccination. You won't have a problem with or without the vaccination in the next 10 years, but maybe you get cancer without the vaccination after 30 years, and that's what you try to avoid. So you have to think that through. Now, there are examples where everybody has to die, right? So in the end, everybody is dead. Then the question becomes the timing of death, right? So we will see how we solve that here. And these are usually Markov models. They deal with the time. So one answer is, with Markov models, you can do more there. What's the next chance node, the green circle on the bottom branch? What's the next chance that comes in here? Yeah? Cure or not cure? So we call that cure or progression. And with the progression now, the if-then rule, gets active, and that means progression, which means amputation above the knee, which itself then can lead to death or alive. So that's my structure. There's one piece missing. I have to put something to the end node. I have to tell what I'm interested in. I'm not interested in quality of life yet, so it's survival. So we put survival here on the top, and now we try to give numbers to this. In this case, it's easy. Survival, somebody survived, gets a 1, and if somebody didn't survive, it's a 0. So we add these points here. And that's very simple, but we also usually want to start simple and then get more complicated. So we will do our first modeling step in terms of parameters. So now we have the structure. You also have some parameters already at the end, but these are not really numbers. These are numbers nobody had to measure. 0 is death, and 1 is survival. That would be different when we have to elicit utilities or quality of life numbers to make a different number for alive after immediate amputation below the knee and alive after immediate amputation above the knee. We're not doing that yet. So now I feed in the remaining parameters. In this case, it's the probabilities that these chance nodes happen, or that these events after the chance nodes happen. So what's the probability of dying in the upper branch? 1%. So I write in a 0.01. And what's the probability of being alive? 99. So that's an easy one. So we put in these two probabilities, which have a sum of 1. What's the probability of cure in the lower branch? 70%, right? And then we're done if you're cured. But if you're not cured, then what's the probability of dying after the amputation above the knee? Who remembers? 10%. So we put in 10 and 90%. So that's putting in the parameters. And if we do bigger models where we need, 500,000 euro or dollars from an NIH grant, we just have more numbers and more branches and a bigger model. But the principle is the same. So now we completed that model. How many numbers did we need for that very simple model, not looking at quality of life yet? 3 numbers, right? It's the mortality of each of the amputations and the cure. So that's what you said before. And somebody said, and then I would need the weighting of the quality of life, and we do that later. So that gives us then 2 more numbers, because we have 2 quality of lives after the amputations. So the next step, after we have now completed the model, is doing the calculation. And we call that averaging out and folding back. So what will happen now is we start from the right to the left. This is what we do in decision analysis. It's called recursive problem solving. You start at the very end, and then you bring everything forward. So the first thing we would like to calculate is at each of these chance nodes. So I put in a bubble for each of the chance nodes and say, well, if I stand at that chance node and I don't know whether I'm dead yet or not, I can calculate a so-called expected value. It's an average of the ones being alive and the zeros being dead, weighted with these probabilities. So I say that in a very sort of explicit way, and then we simplify it. So what's my life expectancy at that point, immediate amputation below the knee, at the chance node, before I know that I'm dead or survived? What's the probability of surviving, because survival is my endpoint? 99%. So how I calculate that, how the computer calculates that, is that, well, I take a 1% weight for the zeros. So 0.01 times 0. That gives me the reward from that part of the branch, which is 0, plus, and then I add the 99% times 1, so 0.99 times 1. And that's a weighted average of zeros and ones weighted. The weights are the probabilities. Now, in this case, it's very simple. It's 99, 0.99, 99%. We do the same below, because we're done with this branch. That is actually the expected value of survival for this action, for this branch. That's the result, a 99% survival. What happens at the bottom is we calculate the same here, and we get the 90%. Now it gets a little bit more complicated, because the next chance node, which is before we know cure or progression, must calculate how. Who can give me the formula, number by number, how you would put it into your pocket calculator? Very explicitly, how the computer does this. Give me the weighted average. So what is one branch that can happen? It's the Q branch. So what's the part I calculate here? 0.7 times 1. Thank you. So that's 0.7 times 1. That's 0.7. Plus, and the lower part is 0.3 times, and you now already have the result, which is the 0.90. So you take the 0.3 times the 0.90, and that's 0.18, and you add that to the 0.7, and that's your last sum, 0.97. So the lower one was 0.27, I said it wrong, I guess, 0.27 added to the 0.7 is 0.97. Yeah? Yes. I will actually do it one more time, because I want to explain you why we call it averaging out and folding back. So I go back and do the second branch again. So the first thing is we start at the right, at the leaves of the tree, and we say here are 2 little branches, and now we would like to average those out and replace the 2 by one number. So when we have them averaged out, we take these whole 2 branches, fold them together, and they're in one number then, and that's the yellow bubble here. So you could actually delete these 2 branches after having done that calculation. That's what we do. So let's do that calculation. 0.10 times 0 plus 0.90 times 1. I do that on purpose, so technically, because that's what the computer does, and you can't make mistakes if you do it that way. So that gives the 0.9. And now imagine that these 2 branches are gone. They are all folded in here. So the two branches, dead and alive in the lower branch, they are now folded into the yellow bubble 0.90. They're gone. So now we have the next bifurcation is cure, leading with a 70% chance to a 1, and its progression leaving with a 30% chance to an outcome of 0.90, an expected value of 0.90. So you do the same thing again. You now do 0.70 times 1 plus 0.30 times 0.90. And then you collapse all these branches into the prior yellow bubble. And then there is no branches left. And that's your result of the lower branch. Does that make sense? There are different, programming ways to do this, but that's how we think of it. And all these numbers make sense because when you sit in such a yellow bubble, before you know what happens, that number gives you the expected value. So the survival, before you know whether you're cured or not, the survival chance is 0.97, right? And we could have known that before because out of 30%, 10% die. 30% times 10%, that's the 3% mortality, so 0.97 survival. But when you have 50 or 100 branches, you have to do these calculations or let the computer program do that for you. So what you see here, these branches and these numbers, except the yellow ones, are the things I generate in my computer with my software. I click and I drag in nodes, I click branches, and I plug in numbers. So I click on a branch and then I type in the number. I show the computer where I want to position a number with a mouse, and then I write in the number. And then I click on my menu and say run, and then the computer gives me the yellow bubbles with the numbers in it, right? Because that's something, now we have calculated it. I've sort of given you the stress of these calculations, and the computer can do that for us. So the last thing, now we have to find the branch with the maximum expected outcome. And sometimes that's not easy. Here it's easy. So what is the best one? Is it better to have a 99% chance of survival or 97? So it's the upper one. So we delete, we prune, we cut off the second arm and say not good. So we stick with the first. That's making the choice. Unfortunately, some of the computer programs do that for us too. But that's where I would say wait, look at it and make the decision. Let the decision made by a human, because you can make easily errors and you code, you can say the one indicating survival is actually the bad outcome and not the good one, and then everything is bugged. So look at your results and make that decision. Now we want to go to the next step. We want to incorporate life years. Before I do that, any questions about the principle of this decision tree and the averaging out and folding back? So these are, the next step is now we want to do life years, because we really want to know how much life years we gain. And the result, I can tell you already, will not be different, because what we assume at the right side of the slide, now we have life years, we assume that the progression is very fast. So people know that within weeks. And the remaining life expectancy of that patient with that age and with the diabetes, with the background mortality of other things, is 20 years. And it's not affected by the amputation. You can imagine that's realistic. Amputation may affect quality of life, but not too much the risk of dying. So what now changes in the outcomes? What number do I put after the cure? Somebody's cured. How many life years that person has to live still? 20, right? Because that's the life expectancy of these people. So 20. What about the person being alive after amputation, below or above the knee? Also 20. So we're just replacing the ones with a 20 now, right? So that cannot change the result. Everything I've calculated before is not just multiplied by 20. But that's the type of decision modeling we do. We're interested in life years, not because everybody dies eventually. Now you can see if some strategies delay death or have it earlier, then that goes into these analyses, whereas everybody would be, sort of dead at some point. So if you do the calculation, we have now, you can calculate these numbers, and we have the same winner, which is immediate amputation below the knee. We prune that tree, and we say immediate amputation below the knee gives us the maximum life expectancy. The numbers are really different because now you see already something, what that means. On average, that means with this decision, we gain 0.4 life years. And some people may say, well, that's not enough for me to risk something. But of course, in the end, people die or don't die. They don't get a half-life. So that's the principle of decision analysis. That's how I learned it in my first class in a public health, Master of Public Health Studies. What are we not happy yet with? Why don't we stop here? Yeah, because we want to include quality of life. We want to see the thing that drives us is the cure. We want to give more weight to the cure than to the amputation. And currently, we're giving it the same outcome. So the next thing is we incorporate quality of life. And basically, what in the end we would like to have is a combination of the quantity, the duration of life, and the quality of life. So in some more complicated situations, you have to go through a chemotherapy, and your quality of life is heavily reduced, but you do that because afterwards you gain. If you don't take the chemotherapy, the first quality of life years are better, but then you have a shorter life. So we want to have that combination of length of time and quality of time. And we really multiply the two with each other, and that gives us the life years times quality, and we call that quality adjusted life years. Basically, it's quality multiplied life years. And those can combine duration and quality of life. Give you an example. So if somebody lives in 10 years of full health, that would give 10 years times perfect health, 1. Highest score, 100%, that would give 10 times 1 QALYs. If somebody lives 5 years in full health, that gives me 5 QALYs. What do I get if somebody lives 10 years and 50% of health? Also 5 QALYs. So 5 QALYs can be different things. It can be 5 full health years, or it can be 10 years in half of the health, or it can be 20 years with 25% of health. But that's sort of the combination we're interested in. There are other concepts, and some people say that's too simple, but it's less simple than just looking at one or the other. So on this slide, I show you how QALYs can be understood visually over time. So you see the x-axis going from time 0 to year 4 and 5, for example, here. And on the y-axis, you see the quality of life index. And index in this case means a single number, because quality of life can have different dimensions. You can talk, you can interact after an amputation, but you cannot walk as well. But summarizing this in one number, and there are methods to do that, one of them I will show you, gives me a number between 0, like death, and 1 would be the best possible health. It's not like perfect health. I'm not, Superman or Supergirl, but it's what I can get as a diabetes patient, the best imaginable health. And what we see here is somebody who lives with a half quality of life for 4 years. So that's how many QALYs, 4 years times 0.52 QALYs. And now you can increase QALYs by adding quality of life. Let's say that patient has 0.7, maybe through some pain-reducing drug, or maybe to some statins that prevented chest pain and so on. So that would then lead to an additional 0.8 QALYs. You can also get more QALYs by extending the life and not changing the quality of life. In this example, add just 1 year of 0.5 gives you additional 5 QALYs. And you can do both. And then you get the extra upper corner where you have a longer and better life, and then you have a new definition. So now we have 5 years times 0.7 overall. So that's how we see QALYs. Now that's very hypothetical. The next slide shows you how two different interventions could work. So the blue line, A, is somebody who has a quality of life of 0.4, has a severe disease, and will die after 5 years. Now what you can do is you may treat that patient, and that immediately increases the quality of life, and after some adaptation, you may even go higher, and then in the end, the patient will die as well, but maybe later, and you see with an older age, the quality of life goes down as well, or maybe that's a late complication of the original disease. And we are interested in the difference between these two lines. So that's very important. We're not so much interested, oh, how much QALYs can I get? We're interested in an intervention, and in all decisions we make in our life, if we do it right, if we are outcome maximizers, if you do a good job, we're only looking at the differences. Where am I, and what can I get in addition? So that's epidemiology, health technology assessment, decision sciences, and if you're a smart person in your personal life, you also sort of, okay, I pay for something, what do I get for that in addition, and what do I have to pay in addition? What do I have to suffer in addition? What is my additional side effect? Because we live a long life anyway without drugs. That's a given. So the question is, what can we get in addition? So sometimes I say we are comparers. That's decision-making is about comparison. It's not so much about the absolute value. If I tell you, well, I give you a drug, and that means your life expectancy, you know, I have a severe disease, your life expectancy is 20 years. That doesn't tell you anything. Maybe without the drug, it's also 20 years. Maybe without the drug, it's only 2 years. That makes a huge difference. So that's what you get. And what you are willing to trade off in terms of harm, side effects, or the society in terms of money will depend on that difference, whether you gain a day or a year or 10 years. So we're incrementalists. This is from a book showing what QALY means. In this example, it's quality of life, health-related quality of life on the y-axis, and on the x-axis time in years. And this compares dialysis and kidney transplantation. So the solid line shows you the life of a person remaining on dialysis. Over time, quality of life gets worse and worse, and then the patient dies. And what happens with kidney transplantation is that you get the kidney and you have to treat the immune system, and it feels worse in the first maybe year. And quality of life goes down, and then it goes back to where you were before, and then it goes actually better, and you have more freedom and are not bound to the dialysis center. And then in this case, we assume that that patient didn't even live longer, but had a longer life. So what is the increment between these two curves, or areas under these curves? It is basically the area B is what you can gain with kidney transplantation. A is what you lose, so you have to calculate B minus A, and that's the additional, B is bigger than A, that's the additional QALYs you will get here. So that's how we think of QALYs. Now, how do I get these numbers? How do I know somebody on dialysis has a quality of life of 0.7, 0.9? Where do we get these? You know, these numbers don't come with a disease. Somebody, you know, that's a construct we have. And there are so-called quality of life index tables. And these quality of life indexes we call utilities. Utility like my health altogether is util for me to live, and that's the utility. It basically means my health packed in one number. My current health. It can change over time, but it's always one number every day. So a healthy person, 1, and a dead person, 0, and then you see some sort of severe disease like heart failure, New York Heart Association classification 4, basically, you know, having difficulties to breathe, already lying in the hospital bed is a very bad thing, so that has 0.3. Heart failure classification 2 is much better, 0.9. Mild angina pectoris is 0.99, so there is some pain, but maybe just sometimes. So this shows you that you can rank these utilities. This still doesn't answer the question where they come from. So I will do one example, one method with you that shows you how they are generated. But let's not forget where we are. We are at our tree, and we just did a little vacation from our tree and thinking about what quality of life means. So what we need now for that tree is what? We would like to embed quality of life. So you see these question mark here. We want to have the QALYs now, the life years multiplied with the quality of life. So what do you have to write in this box after alive in the upper branch? How do you calculate your QALYs? One thing you know already, one part of the quality. QALYs is lifetime multiplied with quality of life. So, how long do these people live? What did we say? 20 years. So it's 20 times, and let's call that number B, because it's the below the knee amputation. So B stands for the quality of life below the knee. We don't know that number yet, but that's the number that comes in. And on the bottom, you see 20 times A. Is B bigger than A, or is A bigger than B? What's the larger number? What's the greater number of the two? B is greater because there's more quality of life with a small amputation. And that still fits with our ranking we had in the beginning. 1 is the best, 0 is the worst, and these come in. So the next question is, how do we get these amputations and these quality of life numbers? So one rule is, when you elicit this from patients, you start with a more severe disease, because it's hard to get that with little difference. It's easier for patients to get that with big differences. So what we will do is we'll use a method which is called the time trade-off. And it basically checks how much preference you have for one of these states. What's the best and what's the next best and what's very bad. By asking you the question, well, how much of your life would you be willing to give away if you can get rid of that problem? So I'm asking you the question, how much of your 20 years are you willing to give away to get your foot back? And you will have a different answer when I ask that for you for the small foot amputation and the big foot amputation. You will give more life days, weeks, months away to get the bigger part of the foot back compared to the smaller. I don't know which the answers will be, but that's what it says. And if I'm asking you in perfect health, how much would you be willing to give away to get rid of your problem? I would say I'm not willing to give away anything because I don't have a problem. So that number then is 0. So we're going to play that together. So you trade life years against quality. That's one method of doing it. There are other methods trading the risk of death. We call that the death gamble, but we're not doing this now in this course. It's dangerous. So the QALYs, what we show patients is actually 2 plates. On the upper plate, we say, look, this is your life with amputation above the knee. And you're going to live, on average, 20 years. We don't know because that's your life expectancy, but let's assume it's 20 years plus minus. Now I'm asking you the question, how much years would you be willing to give away? And we move the slider from the 20 to the 19, 18, 70, so that you can spend these years in perfect health. And that's an equation. The upper equation is 20 times B. Now, in this case, we have above the knee A, so it's 20 years times A equals the years I get from the patient, from the lower slider, multiplied with 1. And then I solve that equation for B, and I know what B is, or A is in this case. I make that a little bit less complicated. But is somebody prepared to play that with me? So I show how you do that in practice. It's not a theoretical thing. That's what we do with patients. Somebody, some volunteer? Who cares about foot? Yeah? Wonderful. So I'm asking some trivial questions, not to make fun out of her, but just to check whether the patient really is understanding the gamble. So the first thing is, I move my slider on the bottom to the 20, and I said, would you rather live 20 years with the amputation above the knees or 20 years in perfect health? And your answer would be? Okay, 20 years. So she understood the gamble, what's going on. Now I'm moving it all to the left, and I say, would you rather live 20 years with the amputation above the knee, or would you rather live in perfect health, but you're dead immediately, hit by a bus, no pain, but you're gone in a second? What would you say? Some people think, because they say, well, what is better, being dead immediately or having that amputation? So But most people will go for a living and then say, so I say that question again. So I move the slider to the left, to the 0, and say, you're not going to have amputation, but you're going to hit by a bus immediately, so your lifetime is 0 in an instance of a second. You will not suffer pain because we don't want to mingle in another problem, but you're going to be dead immediately. Do you choose rather being dead immediately? Thank God, because some patients answer differently. Yeah, that's good, then I'm gone and no worries. And then you have a problem because then you may have to talk with the patient whether that's serious and so on, and it could be. I mean, severe pain and paralysis, people wish to die. So then I move to the 18, to the 2, to the 16, to the 4, and so on. I do a ping pong until she says, now I don't know. So let's do that. So would you rather take 18 years in perfect health, give away 2 years to get your foot back? Would you be willing to accept that? I offer you, rather than having the amputation, a life without amputation, but only 18 years, like the devil who asks you for something. You go for amputation. So what do I have to do? In which direction do I have to slide? To the right back. So now I have to ask the 19 and so on. So that's what I do. So, but she was already on the indifference point. So let's assume she would have said, now I don't know. So that would be, around 16, for example, she would have said that's the example I choose, I think 16. Yeah. And let's assume the patient says that's the point of indifference. Yours were more like 19, but for that patient, the foot was much more important. Maybe had a different job or something. And they would say, well, I'm happy to give life years away, but keep my foot. And that would be 16. So remember the 16 for the above, and we do the same for below the knee, and let's say that's 18. So these are the two numbers we figured out. How do we calculate the utility? Well, by solving that equation, or simply, to make it more simple to you, I start with the below the knee, because that's a smaller number. The patient was willing to give away 2 years. So 18 out of the 20 years, that gives my preferences. The higher the number on the numerator is, the less the people were willing to give away life years, the softer the problem is. So if it's just nothing, like some little thing, a one-day pain, headache or so, and then gone, then people would say, I'm not giving away anything of my life. So you would have 20 out of 20, which would give you the 1. If you would give a lot away, then the utility goes rather to 0. So in this case, we had 0.9 and 0.8. Now I take these two numbers. That was my little sort of trip into the world of utility assessment. And that's how we do it. We really talk to patients that way. And there are other methods to do that. And then we plug in this number, and now we can do the averaging out and folding back again. So who wants to do that with me? So what's the 20 years times 0.9? How many QALYs do we have here? That's 18. And we have 16 on the bottom. Somebody who wants to do the bubbles, averaging out and folding back. What do we get at the top? Now you can take out your iPhones or other Android-type devices. No discrimination. So, what did you get? 70.82. So I round those to 70.8. How do you continue at the bottom? Which bubble do you do first? The right one, the last one. So what do you get here? 0.9 times 16. 14.4. And now you do who says the formula? 0.7 times 20 plus, help me with this. I need some feedback. So plus 0.15 3 times 14.4. Does that make sense? So is the silence because it was so trivial that you let the first row do the problem, or is there still some, should I do that again? Should I do it again? Yes. So how do I do the upper calculation? It's always the same thing. Weight times outcome plus weight times outcome. I harvest things by getting those rewards. In this case, these are 0, and those, and I have to add them. So 0.01 times 0 plus 0.99 times 18 gives me that number. Here, at the bottom, I have the 0.70 times 20. That's part of my harvesting. I put that on my account. Plus, I get more. I get 0.30 times 14, because that branches are gone after I did the averaging out and folding back. So that's my new, this node replaces the 2 end nodes once I've done the averaging out and folding back. So I take this. This is my expected value of this branch without looking further. So the full formula is 0.7 times 20 plus 0.3 times 14.4. And the 14.4 I must have calculated before. So now, for that patient who had the utilities, the quality of life indexes of 19, of 0.9 and 0.8 for the 2 amputations, for that patient we would choose what? Which branch? Which is the better branch here? The lower branch, right? So we delete this now. So the decision changed because we have incorporated quality of life, which makes sense. But had the difference between the 2 amputations been smaller, or had the numbers been closer to 1, had people not so much cared about foot, then we would still be on the other side. So it really depends on what numbers you got from that patient. So you can use this method for individualized decision-making, patients plugging in their preferences, and then you can sort of give them an advice and say, look, for you, we calculated this. It's still a calculation. I mean, there are no utilities in the world. They're not existent. We make them up. It's a calculation of times utility. But you could probably delete those from the choices that have very low qualities and focus on the one with the highest, and then talk again with the patient. And they are all just expected values. So the risk averseness may come in of the patient. So this shouldn't be a machine that makes a decision, but it tells you how we do this, how we do decision analysis with all its limitations and its strengths. So now there were a few questions. 1, 2. Wonderful question. So I'm going to repeat this, and then you got your second question. So this is a very important comment about quality of life in general. And I'm not giving you the solution, because it's, as you will see, an unsolvable problem, but we can do something about it. So people adapt, fortunately, to their problems. So we're all afraid of, being in a wheelchair and not having a foot amputation. It's not just the pain, it's what we miss in life. But then we see other people, and then we figure it out. And there is something probably in our brains that helps us to cope, to adapt. And then we say, well, I deal with it. I'm through it. We have people with cancer who say, now I actually appreciate life much more. I spend more time with my family. It was a good thing that happened to me. Now, we don't want to spend money in giving people cancer so that they lead a luckier life. So there's some conflict with this, right? But it is very important that we answer the questions. Whom do we ask about the utility? Is it the patient right now who is afraid? And one of the answers is yes, because When you want to have a fire insurance, we ask you, your house didn't burn down yet, and you want to make that decision. You may listen to other people, and they say, oh, burning the house down, all the emails gone, all the to-do lists, and so that's the best thing that ever happened to me. I'm kidding now, of course. But it may be not so bad as you thought. But still, you make the decision at the time before this happens. So you may listen to these other people. And in this case, it's important that you do make the decision with the patient when you have to make the decision. That is before. You cannot wait. But you can listen to other people. And you can look videos and talk to other people and say, look, this is the measures. And this is part of patient-shared decision-making. We have to explain the patients what we can help to do. And there are prostheses, and you can show that people can walk again, and it's not so bad as it was. So that's what we try. But it's always an imperfect attempt, because what's the gold standard of quality of life? Is it the before? Is it the after? And now it comes even worse. David Kahneman, one of a Nobel Prize winner, the only one in the field of decision science so far, he was presenting at the scientific meeting at SMDM a few years ago when he got his Nobel Prize. What he did is he showed that people always adapt to where they were before. So people, and Bert, you cut me off if I'm taking too much time of this. So people, he made empirical studies showing that men who lost their spouses, their wives, dropped immediately in quality of life, but they came back after some time. Not to where they were before, but close. So we have something in us that brings us to our baseline level of being grumpy or happy. Women, they did the same study. They dropped immediately very fast down, and they came back, and guess what? They were better off after some years than they were before. So the same with lottery winners. They go up and down. So we cope. But that doesn't mean we don't want to have the fire insurance. That doesn't mean we should think about these decisions. And the other thing with the coping is that people said, well, now as I have the problem, I cope with it. I was afraid of having that disability, but now it works, it deals, and I cannot do the things anymore as I did. But that really didn't change my life, my happiness. In some cases, these people recover, and they get, to walk again, or to get rid of their pain. And they say, oh, God, now I know that I was actually unhappy. Now I know what life is. I was wrong. I wasn't actually so happy. I thought I was, but I didn't know what I missed. So what's the gold standard in this situation? So that's a complicated, long answer, which has led to a Nobel Prize. But that's what we have to consider. So people say we should ask healthy people these questions, but that's for making decisions for the society. If you want to make the decision for your patients, you have to ask that patient for the time trade-off. You cannot take the population average, because you want to incorporate the preferences of that patient. So very, very well done. So we close to finish our last calculation. The one thing that is still waiting for us is a so-called sensitivity analysis. So this was incorporating quality of life and averaging out and folding back, which was the last step of modeling analysis. But now what we have to do is we do the last step, very important in decision science, sensitivity analysis. That means, what if the numbers are wrong? What if some of the structures are wrong? What if some of the assumptions we made in our model, simplifying the real world, was too simple? And they can, that can be parameters that we change. That can be structural things in the tree. We can add a branch or remove something. And there are different types. So one of the most important would be in our case, because our colleague here said, in his experience, there is not 70% of cure. He's seen the cases, and that can be a region, or that can be another belief of a colleague, or that can be a hospital which has, more severe cases. So what we would like to do is we would like to make our decision and change it on that parameter, maybe making it as a function of that parameter. So in our case, let's assume we want to do a sensitivity analysis on the 70% of cure, so on the 30% of people with progression. And somebody says, progression is not 30%, it's X. It's another number. It may be 50% or 20%. We just put X, and we call that a one-way sensitivity analysis, which means we change one parameter, and we check whether our result is sensitive to that change. So the rest is what you already learned, but now it gets a little bit more mathematical and interesting. So what is the next? We have to calculate these two bubbles. What's the first one? I mean, on the right side, it's still 14.4. That didn't change. Now, what's the next one? What do you put in here? And say it slowly that everybody can write that down. Because I think the solution is not in your handouts to make it not too easy for you. So what would you write down here? What's the mathematical formula? 1 minus x in parentheses times 20 plus, I would say x times 14.4, so just to make it clear how we did it, but then you turn the things around, and yes, that is what happens. 1 minus x times 20 plus x times this other number. And then the next step is you join the x's and the numbers, and you get to this. And who sees graphically when you draw that function? Outcome is a function. It's 20. Y equals 20 minus 5.6x. What kind of graph is that? It's a straight line. Starts at 20 and goes down with a slope of 5.6. The more progression we have, the worse the outcome is, of course. So who has a pocket calculator and can help me? So we will just, that's our last task before the break. We will plug that onto the coordinate system on the next slide. So what if x is 0? What do we get at the lower result? 20. What if x is 0.5, a high progression? Somebody can calculate that? Good. 17.2, yes. So, and we do that with all the other numbers as well. And this is how we generate our one-way sensitivity analysis graph. We change the number, the risk of progression, or you could also put the Q rate here, going from 0 to 100% or whatever. We change that, and then we look what the qualities change. And we got this first number calculated, and we got the last calculated, and we could calculate all those in between. When we had more time, I usually give that as group work. So the first row calculates this, the second that, and the computer does it in less than a millisecond. So that's my line, how my qualities behave depending on progression. How does the other line look like? That's the line for wait and see. The immediate amputation, how does that line look like? Does that depend on, that doesn't even depend on the Q, so we will have a horizontal line with the value we have calculated before. And that is very nice because it shows you, it gives you another information. It gives you a threshold when the decision tips, which is around 0.4. So I can go to my colleague and say, oh, you're thinking the progression rate is much higher. So if you think it's higher than 0.4, you shouldn't go for the wait and see. But if it's lower, you could do. So I can leave the judgment to himself. I don't even have to know his threshold or his in his clinic or in his experience the progression rate. So this is how we publish things. So then everybody who reads it can say, oh, in my world I'm higher, in my world I'm lower, and then you can pick what to do. So it's a little bit more than just uncertainty analysis. It's already like a subgroup analysis where you can say for those people, for those clinics, this is the right value, and for those it's that. We do the same for a two-way sensitivity analysis. in this case, utility of amputation above and below the knee. And the point, the red dot, shows us where my base case analysis was, the original result. And the areas show me if I change now my utilities of these two amputations, as long as I'm in the green area, I should still continue to do the wait and see. But if I move my point to the right or up, then I can come in a region where I should do the immediate amputation. So you could imagine that each of us has a different dot on this area. And depending whether you're in the green or in the blue, that would be your decision. So this is the end of doing a decision analysis in a very simple way with a tree and with utilities and with lifetime and with probabilities and doing a sensitivity analysis. That's a star slide. You don't even have to digest that. And now we go into the break first, and then we go a little bit deeper in the theory and looking what different things we could do. Are there any remaining questions of clarity before we break? I'm here in the break, so you can also come with your individual problems, thoughts, and talk to me. Also here after the course. Then let's do a break here for 15 minutes. And then we come back here in 15 minutes. And Beate will continue with the second session. Thank you very much.